Okay, so thanks very much, Adam, and thank you very much to the organisers for giving me this opportunity. So I'm going to be focusing on lung cancer trials and also some of the research that I've been involved with at the BCI, which is just a 5-minute walk from here. It has 400 researchers, lab rats, if you like, who are working busily to find new science to develop new treatments for our patients at Barts Health NHS Trust. So I have a small lab here, and my main area of work is metabolism, particularly one nutrient that some cancers have a particular hunger for, called arginine, which is actually a building block of amino acids, of proteins. Okay, next slide, please. So just by way of background, you've heard talks today about breast cancer, about urological cancers, pancreatic cancer. So unfortunately, the patients that I look after and work with in terms of clinical trials are at the lower end of this scale, lung cancer. So you can see 5-year survival. This was the most recent update on the BBC website, is around 10% for lung cancer, 5-year survival. And mesothelioma, which is a particular type of cancer affecting the lining of the lung, where we have actually a very large patient base here at Barts. Historically, actually, you may know that mesothelioma is an asbestos-driven cancer in a large proportion of patients. We had asbestos actually in Barts years ago in the old building, and all the way through the Thames corridor out to Essex, there's been a lot of asbestos use. So unfortunately, we have the highest instance of mesothelioma globally in the UK because of the importation of asbestos. So you can see that actually you heard the talk from Professor Kocher, mesothelioma and pancreas are right at the bottom of the 5-year survival. So we've got a long way to go to reach up to some of these 5-year survivals, such as melanoma, which is now the highest. And actually, this is for all stages, by the way. So just to bear that in mind. So this would be early melanomas and advanced. But actually, melanoma for advanced cancers 10 years ago was below mesothelioma. And there's one improvement that has led to melanoma shooting up to the leaderboard, and that's immunotherapy. That tells you everything, how important immunotherapy has been, and it's now made its way through all those cancers. So in terms of lung cancer, there are a number of types. I mentioned mesothelioma. The largest group is called non-small cell lung cancer. That's probably around 70 to 80% of lung cancers. There are various types in there: adenocarcinoma, squamous large cell, and there's also one very strongly linked to cigarette use. I mean, 98% of patients who get small cell lung cancers are heavy users of cigarette, and that's around 10% or so of lung cancers. That's the most aggressive. That's a bit like pancreas cancer and mesothelioma in terms of lung cancer. Next slide, please. So I mentioned metabolism, a particular area of interest, and nutrients. Cancers cannot do anything if they don't have fuel. Okay, if we think about situations, if you can't put diesel in your truck, whatever, it's not going to go anywhere into your tank, which is a current topic of conversation. If you remove the fuel, the cancer cell cannot move. And the main fuel that for years has been identified, actually a Nobel Prize was given for this in 1931, is glucose. Otto Warburg got the Nobel Prize for medicine in 1931, identifying that cancer cells they have a sweet tooth for glucose, and instead of using it to make ATP, which is the main reason why we use glucose when we're not growing anymore, cancer cells use that glucose to build bits of the cancer cell, so the building blocks. They're not really using it so much for producing ATP, which is for energy. They're using it to make fats, proteins, and nucleic acids. And anybody who's had a PET scan will know that that basis of a PET scan is actually the sweet tooth of the cancer cell. Not all cancer cells use glucose, but when they do, that lights up on the PET scan, a very sensitive technique. Although this pathway was discovered in 1931, we still don't have any treatments based on glucose. We can come to that later if there are questions. It's actually very hard to produce treatments focusing on blocking glucose supply to the cancer. Next slide, please. But there is a nutrient which actually, around 1930, that the first publications came out on this, somebody called Gilroy up in Scotland, who showed that you could remove arginine, an amino acid, from certain cancer cells and slow them down. That was done in vitro in the Petri dishes, also done in mouse models. So we've known about arginine a long time, but it's only really in the last 20 years that we've got some drugs that can selectively remove arginine from the cancer cells. So some cancers use arginine to grow, just like they use glucose. But the good thing is, arginine is a non-essential amino acid for our cells, so we can actually make it ourselves from other building blocks. Some cancer cells cannot do that. They don't have this enzyme called ASS1. They switch it off. One of the reasons they do that is because they then divert, just like a floodgate system, they direct the flow of those of those chemicals into production of DNA and RNA. So that's the advantage of some of these cancer cells losing ASS1. And we do test patients for trials for that target if they have ASS1 in the tumor, and if they don't. If they have that in the tumor, lots of studies have now shown those patients have a better prognosis. And some of the patients that have the more aggressive cancers, they lose ASS1. But that gives those patients a situation where there's an Achilles heel for the tumor, where you can actually starve that tumor of arginine using drugs that are out there. And the company we've been working with, Polaris, make ADIPED20, which is actually an enzyme made from bacteria. Next slide, please. So what does this enzyme do, this drug? Well, it's given as an intramuscular injection once a week, usually in the arm or in the muscle in the upper leg. And it converts arginine into another amino acid called citrulline ammonia. As I mentioned, that tumor doesn't have the enzyme to make arginine, so you're basically starving that tumor cell. And that tumor cell doesn't like that, it gets stressed. And in the Petri, this is a very easy experiment to do. After 7 days, pretty much all the cancer cells are wiped out, just as if you'd use a chemotherapy drug or some other more toxic agent. This is completely benign for normal human cells because we have this enzyme and we can make arginine. We don't care if we're being starved of arginine. Next slide, please. So this was work I did actually back in early 2000s. This was the publication in 2006 during my PhD. And we looked at mesothelioma cell lines, and we found that half of them didn't have this enzyme ASS1. Actually, I was working, my PhD was on ovarian cancer, interestingly, but I switched to mesothelioma because we found this as a sort of more common feature in mesothelioma. And you can see here that if you take a mesothelioma cell line, you add this drug, or you can do it just by putting media tissue fluid on the cancer cells without arginine. As I mentioned, over a couple of days, those cancer cells are basically dying. That's some of the work to show that. And this is actually a test of a patient's biopsy with mesothelioma. You can see the top panel there, no expression of this enzyme. So that's the type of patient we would consider offering this drug to because that tumor doesn't have the enzyme ASS1. So technically, we should be able to starve that tumor, stress it. But this tumor has lots of ASS1, so that tumor should probably, wouldn't mind having arginine removed because it's got the enzyme to make the arginine. Next slide, please. So that led to a study that took 10 years to complete. And you may ask why it took 10 years. I can tell you over a pint sometime. There were lots of steps. We got funding from CIUK 2006. The trial didn't actually enroll the first patient, if memory serves me correctly, in 2012. There was a lot of paperwork. Plus, this was the first trial that actually imported this drug. So I had to be involved in sorting out importation of the drug to the UK in a hub, Fisher Biosciences out in Hertfordshire. So anyway, there was a lot of work involved. We recruited around 70 patients or so. It was a 2-to-1 randomization. So 2/3 of the patients got the drug as an intramuscular injection once a week. We had tested their tumor and shown that it lacked this enzyme. So that was the population of patients who were hoping this drug was going to help. And 1/3 of patients were given something called best supportive care. Again, something we can discuss, but quite a number of trials do involve best supportive care. And this actually means you're offering treatments such as painkillers, steroids, but not actually giving an anti-cancer treatment per se. But those patients are all being followed up very closely every 6 weeks with a CT scan. And all we wanted to tell in this study, the primary so-called endpoint, was could we detect a difference in slowing the growth rate of this tumor? We're not really looking at survival. Our main goal and it was statistically powered to see could we impact the tumor growth rate on the CT scan. We did do some PET scans as another side project. And next slide, please. So the trial was positive. It's actually the first positive trial of using an arginine starvation drug in any cancer, in mesothelioma. And you may not think that's a huge improvement, 1.2 month difference in the slowing down. So you can see these patients who were on the weekly injection, their tumor was growing much more slowly. These patients' tumor was growing much more quickly and they were coming off the trial. The drug was really quite safe. We did see 10% of patients get allergic reactions because it is a foreign protein made from a bacteria. We did look at overall survival, and you can see actually there was a trend for more patients being alive. There was a small number of patients reached out to 3 years on this trial, bearing in mind that usually the median survival that's mentioned to patients with mesothelioma is around the 12-month mark. Next slide, please. So we went back to the lab, say it's just a 5-minute walk across the way, and we were trying to understand what this drug was doing by removing arginine cancer cells. And we did some DNA, some RNA studies, and we found, very interestingly, that there were some enzymes that one of the classic chemotherapy drugs that's used for mesothelioma called pemetrexed, which is an antifolate. It's also used in breast cancer, for example, and bowel cancer, 5-FU, as a whole class of drugs. We found that we could improve those drugs working more effectively on the cancer cell by just removing arginine. So it's like if you pull out the arginine under the cancer cell where it's being treated with pemetrexed, you could increase the kill rate. This is in vitro, by the way, in a Petri dish. But we also did some studies. That's a PET scan of a mouse. You can see a tumor there. After 24 hours of arginine starvation, that light bulb that's coming up, you can see that it's using a lot of DNA molecules. It shuts down. So we found this very interesting observation that by removing arginine, we could improve the effect of the drug pemetrexed, which is used with cisplatin or carboplatin as a standard and still the only standard of care for mesothelioma. So we wanted to do the next trial, which we moved from the ADAM trial now to the TRAP trial. Next slide, please. So the TRAP trial, this was the first 9 patients who were enrolled. So first in man, not of each drug singly, but the combination of all 3 together. You can see that the arginine levels in the patient's blood dropped and the citrulline, which is the breakdown product, goes up. There was some antibody being produced against the drug. This is part of the allergic reaction situation. So we do see some antibodies being produced against the drug. But what we found very interesting in a trial where we would have expected at best 40% shrinkage, we found in our 9 patients, 5 of whom had mesothelioma and 4 had non-small cell lung cancer, specifically adenocarcinoma, we found shrinkage in all the patients, and actually 80% had more than 30% shrinkage, which is actually a particular metric that we use in trials. If you have more than 30%, it's big tick, partial response. And this is a patient with a very aggressive mesothelioma called sarcomatoid. Unfortunately, patients who are diagnosed with this cancer have a median survival around 4 to 6 months. It's a bit like pancreas cancer, as Professor Kocher was mentioning earlier. And this patient, within a first cycle of treatment, was already feeling better. This is his scan after 4 cycles. You can see the tumors had a very nice shrinkage. All his symptoms disappeared. His pain went, his night sweats went, his weight loss improved, his appetite came back. He actually went and bought himself a new car because he could suddenly see perspective. Next slide, please. So this, what's called phase 1 trial, actually included a number of other patients. So it was actually a 100-patient study. We also had some other arms looking at patients with brain tumors and also eye melanoma, which was just recently published. But anyway, the main force of this study was to look at lung cancers and mesothelioma is where we're at currently. This led in 2016 to opening up a global trial. So opened in all the big centers in the UK, in the US, Memorial Sloan Kettering, MD Anderson, in Italy, in Taiwan, Australia as well. A number of centers opened up, and we just finished recruitment in August of last year. Actually, I broke my arm just on that's the day. Fell off my bike, broke my arm. I thought this is not going well. But anyway, we got the last patient recruited. It was a real struggle because COVID severely impacted, obviously, recruitment, and particularly patients with lung cancer, patients not even being diagnosed readily. And as I say, time is of the essence of this disease. But I just put up one case study there. This is a patient, Fiona Holmes, who was on the study. She wrote up her experience in the Mesothelioma UK newsletter. You can read about it on the website, the Oral Archive. This is her daughter who was doing a master's, and really Fiona's only goal in life was to see her. She took part in the trial for all the reasons we've sort of discussed today, and she again was expected to live around 6 months, lived 2 years on, so sadly no longer with us. She got to see her daughter graduate. That was her goal. So with a terminal illness, you do have to set goals. You don't know how long you're going to be around. This is an experimental trial. But you can read there, her pain got better, her tumour shrank by 70%. Okay, next slide, please. So I hope to share those results with you later in the summer this year. That's when the trial is going to read out. What about immunotherapy in mesothelioma? So a few other trials we've been involved with recently. This is a trial of nivolumab versus placebo in mesothelioma. So it's now been approved under a COVID measures scheme, so we can use this for patients second line. But this is the study at the time. Patients couldn't, the only way they could get access of this drug in the NHS was through going onto the confirmed trial. We recruited, I think, around 10 patients or so, and there was a 3-month increase in survival. You can see the red line is the immunotherapy arm, the blue line is the placebo, and that was also a 2-to-1 randomization. So you had 66% chance of getting the immunotherapy, 33% chance of getting placebo. That was published last year. Next slide, please. So is there a new treatment? We've had the chemotherapy I mentioned for the last 17 years with no new license approved in the NHS at the moment. So this is currently still being discussed by NICE, but this is the double immunotherapy, which is active in mesothelioma. And you can see there's a benefit. And the blue line is the immunotherapy, the red line is the chemotherapy, of around 4 months median improvement. But you can see that at 3 years, there's around 30% of patients alive compared to 20%. So I mentioned earlier the 5-year survival is 10% for mesothelioma, just under. You can see that it is improving, at least based on these studies. The 5-year data is not quite ready, but we are seeing a plateauing, and there are perhaps a doubling of patients alive now at 5 years if they can access these immunotherapy, these more modern treatments. Next slide, please. So the other trial we want to offer patients, we're having a discussion at the moment. This is a US-Australia study. The UK, because of our large patient population, has been invited to participate, called the DREAM 3R study. And this is classic standard chemotherapy versus the double chemotherapy with the addition of one of those immunotherapy drugs called nivolumab, which you heard being mentioned earlier in one of the urological talks. So we seem to be pushing out the median survival to 2 years now with this triplet in the small studies. And the idea is this going to be better, particularly for the more slow-growing mesotheliomas, what's called the epithelioid. This really wouldn't be the dream ticket, if you like, for those with the non-epithelial, which are those aggressive, the picture I showed you of a patient with sarcoma. So those patients really should be offered the double immunotherapy, or potentially, depending on the atomic meso results, arginine deprivation. Next slide, please. So we're also very keen to launch a new study. Negotiations are underway. We have a protocol written called atomic small cell. So I mentioned small cell is a very aggressive cancer. There's early data to suggest preclinically mouse models really feeds on arginine in a big way. And the standard chemotherapy for the last few years has been one of the immunotherapy drugs, atezolizumab with carboplatin and etoposide. And we want to add ADI-PEG20, the arginine starvation, as a 4-drug cocktail to see if we can improve the survival, which currently, even with the triplet chemoimmunotherapy, is around 12, 13, 14 months median survival. And we've shown, based on some biopsies in our TRAP study in our lung cancer patients, that we are affecting PD-L1 levels and also T cells. You can see T cells are pretty separate in this baseline biopsy before the patient went on to trial, and then lots of T cells getting together around the tumor cell. Next slide, please. And then finally, an interesting study, which we have a site initiation visit very shortly, is a new drug. Well, it's actually not new, but it's a new formulation of an old antibiotic from streptomyces, a bug that grows in the ground, likes to grow where there's very little oxygen, decaying vegetation, for example. And this antibiotic, RS00215, strepton, is going to be delivered through a drain into the chest weekly. And we're looking for patients with mesothelioma because you may know that patients often present with fluid in the lung, but it's applicable to any patients with solid cancer, including breast cancer, lung cancer, ovarian cancer, gastric cancer. Those cancers can sometimes also develop fluid. And this is actually first in man trial. So this drug has not yet been tested in humans at all. We're doing this trial here at Barts with a couple of other centres, including Guy's, Oxford, Newcastle, Leicester, and Manchester. So we're very excited about this study. We'll be quite involved because the patient has to have the catheter and have weekly administration of this drug. But this may lead to a novel area of what's called pro-oxidant therapy. What this drug is, it produces lots of free radicals, and we know that cancer cells don't like free radicals. Actually, part of the way chemotherapy can also work. So I'd like to finish there, and thank you very much. Happy to take any questions.